I'd like to call the meeting to order. Madam Secretary, would you please call the roll?
Director Harrington,
Present.
Director Webster Cross, and Chair Curry.
Present.
You have a quorum.
Thank you. Madam Secretary, do we have any direction for voting?
We do not.
Thank you. The next regular meeting of the Managed Care Committee will be held on Friday, October the 18th at 10:30 a.m. Madam Secretary, has anyone registered to provide in-person or virtual testimony or submitted written testimony to be included in the record?
We did not have any registrations and did not receive any written testimony.
Thank you. With that, we'd like to move on, and we'll receive the report on health plan services from Mr. Aaron Galena, who's Chief Administrative Officer of Health Plan Services, who will review the report and the metrics. No action or motion is required. He is only presenting information. Mr. Galena?
Thank you, Chair, and good morning, directors. We'll start today with our membership slides and go through some of our usual metrics before turning it over to Dr. Collins to talk through some of our quality data, which will also be a precursor as we head into the fall, where we'll have some more detail around comparative rankings on our quality data with national benchmarks and as well as other plans. And then we'll also cover some strategic initiatives that are currently underway within the health plan. So starting with membership, as of July 5th, we're at 426,000 members. This is a slight decrease from the prior month, mainly due to redetermination, which I'll talk more about in a moment. The next slide shows our current market share data. We're at 34.2%. This is a 1% increase versus where we've been running for much of the past year, which was closer to 33%. So a fairly significant change in the overall market share, which is on a base of almost 1.3 million members across the Cook County Medicaid market. The rest of the market has been relatively steady. We've seen that market share that we've gained come relatively proportional from the other health plans. Most of our market share gain has also been due to us bringing on almost 35,000 healthy benefit for immigrant, adult, and seniors within our plan from January through April. The next slide, you can see some of these trends and the impact of that on the market share. So the red line on the right is the overall Cook County Medicaid managed care market, and you can see it's been shrinking over time as the impact of redetermination has taken hold over the past year. County Care was following that same trend, so the blue line on the left, until about January, which is when the HBIS population started coming into County Care. So January through April, those members were being transitioned in, and as I said, about 35,000 in total individuals came onto our plan during that time. So you can see that's really when we started increasing while the rest of the market was decreasing. This budget slide shows our membership compared to our initial budget projections. The blue bars here is initial budget forecast. The red or orange bars are the actuals that we have to date. You can see, as I just mentioned, we peaked in terms of membership in April. Again, that was the last month of the transition in of HBIS members. And then we've had some decreases for May and June, which is due to the impact of redetermination continuing. We are almost through the large initial wave of redetermination. This is the first time individuals have had to go through redetermination since prior to the pandemic. So we expect that we'll continue to see that impact here for the next couple months, and then our membership should stabilize at that point and kind of flatten out for the rest of the year. The next slide shows our operations metrics. No real callouts here. All are within SLAs. We've been tracking, especially these call center metrics, really closely throughout this redetermination period. We want to ensure that anyone calling in and reaching out that needs connected to that assistance during the READY period is getting that and getting that timely and quickly as they call in, and of course the variety of other needs that members call in to address. The next slide shows our utilization data. This is prior year versus current year. You can see generally we've been pretty close year over year in terms of our inpatient admissions per 1,000, with some slight decrease generally. We are expecting that trend is going to reverse. So if you look at the light blue shading, that's our projections going forward, which we use some prior authorization data and some actuarial analysis to project forward. We're really expecting that trend to invert because of the changing acuity within our population as redetermination continues. So the individuals that are more likely to stay with the plan through the redetermination period are those that have more significant health conditions than the overall population that we've had prior. This next slide shows our claims payment trends. We're continuing to hold just above the 30-day mark. No real call out here. I expect that this will continue to trend slowly downwards. Our target's that 30-day line, which we're hopeful that we'll be at as we look forward through the end of July when we run that data. And then the next slide here just shows that broken down by aging categories. So you can see most of that aging is in that 30 to 60-day bucket, which is really where we're trying to drive down and eliminate that bucket entirely so that we're really just focused on the 0 to 30-day category. I want to take a moment to recognize a couple awards that the health plans received since we last met. So there was National Association of County Awards program, which is called NACO. There was 3 submissions we did for the health plan, each of which received an award. So the first is around addressing food insecurity with our food care program, which won the Best in Health category. I believe this is the first time across the county that there's been a Best in Category award given to Cook County. So we're very proud of that and some of the impact we're seeing from that program, which we'll touch on a bit later. We also were recognized for how we've engaged members during this redetermination period, as well as a lot of the work that we've done to improve our member demographic data, which is information that underlies a lot of work we're doing across trying to close health disparities, across trying to do outreach for redetermination, and a number of our other quality and other initiatives that we have happening across the plan. The other recognition we received was for the Astor Awards, which is a award related to our marketing campaign that was in market for the 2022 to 2023 period, called There's a Plan for That. And so we're very excited and thankful to Alex Normington and the entire marketing team for all the amazing work that they've done for us over the past couple of years.
I want to commend you on winning not just one, but 3 national awards. I think that speaks well of the health plan and the work that's being done. So I want to commend you and all the employees.
All right, and with that, we will move to the quality section of our presentation, and I will hand it over to Dr. Collins, our Chief Medical Officer.
Good morning, everyone. Our first slide, if you look at row 1 and 2, is a comparison of measurement year 22 compared to 23. What we really want to highlight here is the number of increases in terms of stars. This is a 5-star system. Our goal is always to be a 5-star health plan. And if you look at the 4 stars, we doubled, particularly that area, the number from 2022 to 2023. If you go to the next slide, it highlights really where those changes were. So if you look at the graphic in totality, it's the trajectory. The green is where there was improvement. The red is where there was opportunity. Nearly half of our measures increased from last year to this year. So if you look at the focal areas, women's health, living with illness, that is chronic diseases, and keeping our kids healthy, all improved, either 1 or 2 stars over those 2 years. There's some opportunity for behavioral health. 2 of those areas decreased by 1 star, and I'll talk about that as we talk through initiatives that we're focusing on for the remainder of the year. Next slide. This is our focus. We focus really wholeheartedly on maternal and child health, behavioral health, and primary care engagement. For primary care, we understand that that is the entryway for our members to really get all of the health care that they need. So really pushing our members to see their primary care providers, both our adults and children. Those are the first two roles. You'll see an improvement from measurement year 22 to 23 for both of those categories. The next two areas were behavioral health focuses, ensuring that we can identify and follow members those initial 7 days post-hospitalization, in addition to post-ED visits. You'll see there was a slight increase for hospitalization, a little bit more opportunity for ED visits. What we're finding, probably the main issue that we're seeing is being able to identify them in order to intervene. Doing some work in terms of some providers that we're working with to really go into our facility so that we can know our members are there, interact with them, ensure we have the correct information so that when they're discharged, we can follow up with them. We have created some of our own assessments so that when our care managers are able to reach them, especially post-hospitalization, we're able to close some of those gaps a little earlier than we had been. The last two areas focus around maternal and child health, that is prenatal and postnatal care. Both of those metrics have improved. Really just want to highlight for postpartum care, the significant increase from measurement 2022 to 2023. And again, for prenatal care, it's identification, really finding ways, really innovative ways that we can know that our members are pregnant outside of either them or their providers notifying us. The next slide then focuses on areas of opportunity as we look at the remainder of 24 and 25. Again, with the focus on behavioral health. Again, some of those same measures that we talked about. We're identifying staff that have behavioral health expertise within our teams to really do that focus work. We brought on a significant number of behavioral health teleproviders because access is an issue. So we want to make sure that we eliminate that barrier. From some of our data, when we looked at our maternal data, we found that there was not only within our behavioral health population, but also within our maternal population, a significant number of our members that had substance use disorder. So really doing an all-hands, all-health plan clinical approach to really identifying when there's a substance use disorder concern, getting our care management teams involved very quickly and ensuring that we are knowing sort of along that entire loop of where our members are. We started some work with recovery centers so that when we know members are there, being able to actually go into those recovery centers with our care managers so they understand who we are and what we're doing and hopefully have better touch for the members that have substance use disorder. And the last component, we know part of that treatment is medication. So having our pharmacy team really track those members and if they're not picking up their medications, reaching out to find out why they're not picking them up. In terms of living with illness and chronic diseases, those are all of our really, chronic diseases that we typically look at. We have a focus on high blood pressure and diabetes, really looking at are there other ways that we can educate on controlling those diseases. We've implemented a new pharmacy prescription manager that's helping us calling members if they aren't picking up their prescriptions, identifying why they are not. We've started increasing our focus on delivery because sometimes members have barriers to time. And then the last focal area is really beginning to look at cancer screenings a little bit more in detail, focusing primarily on breast cancer, cervical cancer, colon cancer, and lung cancer, because not only are those metrics within our HECAS metrics, but also we know that when we look at our population, those are where some of our highest numbers are in terms of newly diagnosed malignancy. So really beginning to get on top of that. We've implemented a mobile mammography unit that goes out with us now to some of our redetermination events because our philosophy is get them where we can. So we can get them at the REDI events. We are screening them there. We have some conversations upcoming with a vendor that tells us, I'm going to put it in air quotes, they do mobile cervical cancer screening. I'm a gynecologic oncologist, so that's really exciting. So if that's indeed the case, we would love to partner with them again, moving those metrics a little further. And then lastly, maternal child, our continued focus on both prenatal and, prenatal and postnatal care, with a focus on access. We are finishing our analysis. I think we have said it, but really looking at the data of where the deserts are related to maternal care and seeing what alternatives we have for our members within those areas. And then really, we have not completely recovered, I'll say, from the pandemic related to childhood immunizations. So really looking at education with our vendors around how we are educating parents in terms of the importance of vaccinations, working with those clinics that continue to have mobile immunizations for our kiddos. We're participating in an array of back-to-school events. We've increased our reward funding for some of those vaccinations, but really just looking at ways that we continue to push that. As you guys know, we had a huge measles outbreak earlier this year. There was a small meningococcal outbreak, so really the importance of childhood immunizations can't go ignored. So those are just some of the things. There are lots more, but some of the focal areas that we'll be focusing on as we close out this year and move to 25. Yes.
Yeah, and looking at this, I know that there are unique members in behavioral health living with illness and chronic disease and maternal and child health, but I'm really concerned about maternal health and how many members might have behavioral health problems as well as living with illness and chronic disease, which could really complicate a delivery. And so is that something we've looked at or we could look at?
Absolutely. So when we looked at the analysis of our maternal population, we did see a significant of those that have behavioral health concerns in addition to some of those chronic diseases. Related to chronic diseases, a lot of that is managed within the maternal fetal space. And we continue to educate our providers on pushing members there and the importance really of postnatal care, because some of those are diagnosed in pregnancy, but a lot of the management and those that end up becoming chronic diseases are in that postpartum period. That's why that postpartum period is really so important. When we looked at our behavioral health providers, we wanted to make sure also that we brought on providers that were that had a focus on maternal health. So we have an array in that telehealth suite of behavioral health providers that also are able to help us if we identify on our depression screening in that first trimester that there's a need there for that particular population. They're beginning to hone in on what we can do and what we can do differently. And telehealth hopefully will help us with some of the access issues. And I won't even say access maybe for that population, but unfortunately for the pregnant population, everybody thinks it's a different population because it's pregnant. But we know that that's not the case, but really focusing on behavioral health providers that can focus on that population. We hope to get with some of our telehealth providers.
Yeah, what would be interesting to see where we're trending in maternal and infant mortality relative to these things moving forward. Are we trending? Are we staying the same? Are we seeing a reduction? Or I know there are a lot of things we don't have control over, but it'd be interesting to look at.
Yeah, we look at our maternal mortality data for the health plan with the health plan focus, and what we're seeing is we're not seeing the common things that you normally see cited in literature. It's not really hypertension for us and embolism. It's more violence, and it's more substance use disorder. So that's really why we when we expanded our substance use program, there was a focus on maternal care because we saw it so highly within our population. It's definitely an area of increased morbidity for the health plan population.
Thank you. Yeah, it'd be interesting to see that data.
Yeah, we can present it, absolutely.
Thank you so much for reaching into that substance use space as well, too. That's my passion, so happy to hear that you're going there as well, too, because it's so needed, particularly to prevent late-stage presentation right at labor delivery for women who certainly people feel anxious about presenting prior to that. Do you have universal screening set up currently, or are some programs for incorporating and integrating expert into your primary care as well?
So a lot of our providers already do that. We do have some primary care providers that already do that. I would not say incorporated from the health plan perspective, but when we look at strategies that our providers are using that potentially make a difference, we have seen that. Not across the board, but there are definitely some providers that focus there. We've added universal screening for all of our members in general, but a focus on the maternal population when we look primarily at diabetes and anxiety, but also substance use. That is part of our health risk screening and assessment. What you know is there's some hesitancy, to be completely honest, because of the populations we serve and the disparity, I'll say, in when I report, I'm more likely to lose my baby than when some others report, they're more likely to be able to go into counseling and therapy. So we're working through how we create the relationships to really be able to bring that out when we're having those conversations with our members, but we screen everybody.
Thank you. That's going to be really important too, especially given the disparities that you mentioned. Another disparity that had been discussed previous to this was the utilization of gene screening and gene testing for risk for cancer, particularly women's related cancers, and the anxiety that some may have, particularly in underserved communities, of providing genetic material. Have you discussed?
You are absolutely true. So just for the record, County Care covers all of that screening, especially where there is either increased risk or family history. So those are covered. The anxiety around what will happen with that really is a trust issue and a ballot issue. So as we talk through cultural competence and trust with our providers, that's a barrier that we slowly work through, I hope. But we do cover it. The other part of it, of why it's really important, is we know that we would screen those members vastly different. So our specialty side of the house, which focuses on oncology, does that screening. So now we can say, we know that you're at increased risk of X, Y, and Z. How will we intervene differently? So covered, very commonly counseled for, and some of the hesitancy that we see is really the trust issue. What we actually just had this conversation on Wednesday. What we'd like to look at is for our population, as we start to look at who's getting guideline-based therapy, who's actually getting that genetic screening. So we can see, is there a disparity within our population? We hope there isn't, but there very likely may be, and then what do we do around that? So some newer work that we're doing in the oncology disparity space.
Maybe partnering as well with public health to look at creating some type of messaging or campaign to help with decreasing some of the sadly traditional and current disparities regarding that. But to be able to address that, I think it would also address some of the concerns you mentioned, similarly with behavioral health and reporting behavioral health symptoms too. Thanks so much for the work.
Yeah, thank you for the recommendation. Next slide.
Yes.
This is just a sampling of, as we talk about creating strategy, we have an array of performance improvements and work groups that we have developed across the health plan. A few of them are internal, some external. So we have performance improvement work groups that focus on each of our measures that are put forth from the state. So our pillars are around behavioral health, both adult and child, maternal child, in addition to those chronic illnesses, and then community integration. We have performance work groups around all of those that meet regularly, and those are health plan specific. Then we have external meetings that we have both with providers and with our care management entities. So as we look at the data across our care management entities, perhaps we're able to see that care management A is doing something better than B through D, and we can say, you know, let's talk through what is your process, what are you doing differently that potentially may be a best practice that others can learn from. So we've learned a lot in those partnerships. There is, in a lot of ways, no right way to do it. There are multiple ways to do it, and we want to ensure that we're incorporating all of those in. Data becomes key in so many areas of the health plan, not only because of how we report, but as we talk more about the component underneath that value-based care, we're going to have to be able to gather the data that we're asking providers and other entities that we're doing contracting with to report out on. So we're doing a lot of work around expanding where we're getting that data from, how we're processing that data, and then hopefully how we're presenting that data. And then lastly, value-based care and incentives. Everybody in the room knows for so long it was how much care you did, how many patients can I see, how much can I get through in the course of the day, and we know that did not work. So taking a step back and really looking at how we look at value-based care. So really incorporating a suite of items in terms of how you care for our members and then incentivizing you for that. So just a little bit around how we hope the work that we're doing also improves our performance in all of those HEDIS measures. Next slide. Any questions on HEDIS before I turn over to Kat? All right, so CAPS is the Consumer Assessment of Healthcare Providers and Systems. It's an annual survey that our members, it's like grading the health plan for our members. It goes out at random to members. They're asked a set of questions. You'll see the 9 components are you getting the care that you need? Are you getting it quickly? How is the service from getting your questions answered? How well your doctors are communicating with you? How well your providers are coordinating your care? Then your rating of your health care, your doctor, your specialist, and then your health plan. And so the next slide sort of looks at where we are related to the adult perspective. Yep, thank you. So you'll see the sample size, 2,700 surveys were sent out, 351 were completed. That's a response rate of approximately 3.2%, slightly down from 2023. What you'll see different when we look at the child caps is the completion rate, again, was primarily female, but a slightly older population, primarily by male within the Black and Hispanic populations, were the highest rated populations in terms of response rates. Next slide. When we go into the components of where we measured last year, that is in the blue, to this year, which is in the orange, we'll see that there were increases related to getting the care you needed. I think that's a testament of the work we continue to do around ensuring that primary care providers have access and are providing that member with access, but also urgent care. We saw a slight increase in getting care quickly, pretty much stable on how well our doctors communicate and customer service for this population. Next slide. When we look at the next set of measures, no significant differences outside of rating your specialist. Part of the CAP survey and where we added some supplemental questions was really around, if you're not getting the care that you need, where are you not getting it? And so we identified some specialists where that was the area where there was some problem for members, and really were intentional about ensuring that we could bring those providers into our network. And I think that increase is related to that. And then rating the health plan, there was some increase there, which we were pleased about. Next slide goes into the child caps. Again, 3,630 went out for review. 466 responded, a 12.9% response rate, which was slightly increased from 2023. Again, primarily female, the more reproductive age woman. And then you'll see that in terms of how they responded were different. We can see for this population, they responded more via internet and less so via mail, which we saw in the adult population. The other difference we saw here, the Hispanic population, again, tends to be one of the populations that responds the highest, and then the white population was second. And I think this gave us some additional information. We're trying to really focus on our 21, so 19, I'll say, to 25-year-old population. We know they're not as responsive. They're not seeing their primary care doctor. And maybe this gives us some testament that, again, we have to look at different innovative ways around how we get responses based on how this particular population responded to the survey. The next 2 slides then focus on those same response rates. Again, getting needed care. We continue to hear about pediatric subspecialists and dentistry that are areas of concern for our members, so working around that. So we were pleased to see that getting needed care, there was an increase year over year. The remainders were really pretty stable. What I will say, customer service, we saw a pretty significant drop in the pediatric population in terms of response rates for customer service. If you remember from the adult survey, we were in that 90 range. Same customer service line, same folks answering the phone. No good reason that we've identified as of yet. We're digging into that a little deeper, but was a little surprised at that decrease in customer service for the pediatric population in terms of measurement rates. The next slide highlights those special areas. So we were really pleased at the increase in performance here. So not only the rating of your health care, but the rating of the specialist and the rating of the health plan significantly increased this measurement year, which is a testament, I think, to the work that we're doing, really focused around our CAPS work groups, which I'll talk about in a little bit. Next slide is, yes.
Not a question, but observation on the adult, 2024 adult, what do you call it? CHAPS, CAPS, you just call it CAPS. Yeah, and the 2024 child CAPS, there's a difference in age. One is 55 plus, the other is 35 to 44. And some of the numbers are striking in terms of where you see the significant number of people that actually respond. For 55 and older, it was Black, and for 35 to 44, it was Hispanic. And so it's just an interesting observation. And the other thing is most of these are females, so it seems like males are not responding
Right.
to the same extent or not at all.
Right. Very, very true. That's another area that we've started to focus on. We attempted to do that last year when we started our first men's health fair, to really get men in, to talk to them about the importance of healthcare. But you're absolutely right. Less response. The other thing we're thinking about in terms of getting that population in, both men and our younger population, historically we've done a men's fair and we've done a women's fair, really looking at bring your whatever to the doctor. So women can bring their partners. We're encouraging fathers, significant others to bring their children. So perhaps if we look at it from a more collective view, can we get not only more people in to see providers, but can we increase those response rates?
Yeah, it appears that men are, as the data shows, that are less involved in the healthcare system.
Yeah.
And they don't even respond to surveys.
So that, and I think we have to figure out what's important to them. So what we found in having some conversations at some of our men's fairs is they're very interested in mental health, and they're very interested in sexual health. So really how we tie those into conversations that we have with them become really, really important. But yeah, I think just historically, men are less responsive and less attuned. All right,
Accept
guys.
responsibility for that.
Yeah.
It is interesting to see, though, even in the rating of healthcare and rating of the health plan, the numbers reporting, it is an increase, which is very good from last year, but it's also about 10 points less than what we see for the adult population. Have you seen what some of the tangible concerns are that are lowering the overall ratings of the healthcare and health plan for children in particular?
Yeah, for children, at least we haven't completely combed through 24, but I'll tell you from 23, it was really the kind of subspecialists that we had within the network. There were concerns about pediatric dentistry. There were concerns around orthodontics. There were concerns around, probably, if you take any pediatric subspecialty, there were some that we focused on more so, but I think those were probably why they rated the health plan lower in terms of access.
It'll be interesting to see if that's been an ongoing trend in your reporting of the difference in rating for adults to children, and then what additional shore-ups we can have for children to increase those closer to the 90.
Yes, Colin, let me ask, I'd like to just pin to that. On the adult rating of healthcare, it was 61% or so, some movement. Children start at 68, moved up to 77. So that's our ratings within the plan. How do those ratings compare to the peer group, or overall a 61% rating? What percentile or correspondingly with our peer group entities?
You know, I don't know that I can answer that. I would have to go back. So we do get access when we get our scores, a comparison of, I think, because you're asking about nationally. When you look at, when you look at other plans, how they rank. I can't answer that. I can definitely bring it back and we can look at it. But I would imagine there are some, depending upon what line of business that you look at, I would imagine commercial is probably higher than that. Most of the Medicaid plans are probably, when we looked at it, at least historically in previous years, are about at that level. But we can plan to add that in.
Maybe when that becomes available, it'd be something great for us to look at to see our performance against like plans, similar plans,
Right.
which is real important
As a comparator.
to see what that opportunity is. Thank you.
Absolutely. And then for the October Managed Care Committee meeting, both for HEDIS and for CAPS, we should have all of that percentile data from the national benchmark. So we're happy to bring that back. And to your question earlier, definitely nationally in those benchmarks, there's that same differential between the adult and child ratings. And so that is, to Dr. Collins's point, a lot of pediatric subspecialties, especially in Medicaid, the access is such a challenge, and it's a challenge nationally.
Yeah, another observation, that this is really a subset of the patients that are actually in our network.
Right.
Because some are not using our services at all.
Correct.
That's the other thing. And although access has increased, or access to healthcare has increased, particularly with the Affordable Care Act, we we don't see a similar, I don't know if anybody's actually looked at this, what the utilization is. People actually taking advantage of the services that are available, and that probably is something to keep in mind as we look at this number. This is a subset of the population that we're intending to serve, and so not everybody's using our services, so.
There is some data, though, that shows for both the Affordable Care Act and those that were not on Medicaid who enter Medicaid, their utilization increases for them.
Okay.
Yeah, so we know definitely when they haven't had it and have it now, they tend to use it.
Good to hear.
Yeah. I think that, next slide. Yeah, I'll turn it over to Christy, who'll talk to our strategic initiative.
And just one more interjection before I turn it over to Christy. I just want to take a moment to thank Dr. Collins for her leadership. I know we went through a lot of data, but really the year-over-year improvements are fairly remarkable, particularly on the HEDIS scores. I think we're very excited to see in the fall how we compare to other plans and compare to the overall benchmarks. But I can tell you in my time here with County Care, which has been since the inception of the plan, I think this is by far the greatest year-over-year increase that we've seen. So we're really excited about that. And also want to thank our quality team, Emily Lupo, who leads that team, and really the entire team that I think has bought into trying to drive these scores, not just as a clinical initiative, but really across all of the operations of what we do with the plan. So if someone calls into the call center, for example, they get educated if they have a care gap right there during that call. So we've tried to really build in the processes and the emphasis on this across each of the structures that we have within the plan.
Thank you. I want to echo that and remind people that you can't manage what you don't measure.
Okay.
Yeah.
All right, Chrissy.
Great. So this past week, the Governor Pritzker, HFS, and other government officials came together to celebrate the passing of the 1115 waiver. And 1115 waivers are a pilot or demonstration project to utilize Medicaid dollars for non-traditional Medicaid services. So these are medical assistance for individuals with substance use disorder, some supported employment services, and other services that support health-related social needs, such as housing and food insecurity. So this was passed on July 2nd, and we're really excited to start implementation with the state. There's a lot of services that we've already implemented as a plan, including for our food program, for housing, and other services that we'll just hope to build on as we implement with the state. If you go to the next slide. We also wanted to share an update on a new benefit that we're going to be providing to all county care households with a child 12 years or younger. Senators Duckworth and Durbin reached out and requested that all plans provide a service to prevent lead poisoning in water. And so County Care responded and decided to implement this benefit. We have about 90,000 households that fit into that population. So there's going to be 3 waves of these coupons going out, and members will be able to go to grocery stores and pick them up, really with the goal of preventing lead exposure. So we're excited about this. We partnered with the Chicago Department of Public Health as well as the Cook County Department of Public Health to develop materials on this. So that'll be hitting the mail in the next week or so.
Could I just add to that 2 asterisks? Number 1, County Care is a lead plan, and going forward, the others will be playing catch up with a model. And the second, the coupons are available, I believe, through Jewel Osco. That will be available for people to take those in. Is that correct?
That's correct. So we're building on a pilot that we have for our diaper coupons. We currently have diaper coupons that go to all families with children 2 and under. So we wanted to make sure that it was an established process that'll work well, so that when we send out these 90,000 coupons, no one has any trouble fulfilling those. So we're really excited for the partnership and to get this new benefit in the hands of members. Thanks for mentioning that.
We have metrics relative to this.
metrics relative to who is fulfilling the water filters
More
or
than just
who?
who's getting the coupon. I mean, will we know what impact this has had over time?
Yes, we will. We'll be able to see who's actually fulfilling the coupons. We won't be able to see that at kind of a member level, but we'll be able to see overall of those coupons that have gone out, how many have been fulfilled. So a little bit of an update on redetermination outcomes. We have seen a little bit of an increase at this last reported month. So for May, we increased 5.2 percentage points to 88.9%. And overall, we have, for kind of the full year where redetermination has been turned back on, been at about 84.8%. So that's really great and higher than our expected retention rates. And as Aaron mentioned, we expect to see a little bit of stabilization after, you know, we reach the 1-year mark after the after kind of the resumption of Medicaid after the pandemic.
Okay, I'd like to read in the record again, as it have at the board meeting. Illinois has led the country in terms of redetermination, number 1 or number 2, along with Maine, consistently. And county care among and here in Illinois has led the way in terms of attaining these redeterminations, something that I want to give recognition to the staff for their hard work, their focus, and staying true to this consistently from the beginning to the middle and where we are today. It's something to be recognized.
Thank you, Director Curry. There's been millions of text messages that have gone out, postcards. We've also, up on the slide here, you can see just about a year ago, we started doing redetermination events 5 days a week in the community and have had participation increase over time. So we've held a total of 245 redetermination events as of this last May and had a total attendance of over 10,500 folks. These redetermination events serve not only county care members, but anyone in the community that needs support. We also have DHS caseworkers who are doing the paperwork on site, so processing those on site instead of the back and forth that happens through the mail. So we're really excited about that partnership and the partnership with the state. We also provide fresh food boxes at those redetermination events, and then help with rewards, with care coordination. So there's just been kind of an all hands on deck strategy as part of this, including partnerships with faith-based organizations, teams that are on boots on the ground to get out this information within churches, within the community. So really so much amazing work from our team. And to your point, where we've been at about 84.8%, the state overall has been, and has been a leader, has been at about 78% as of most recent data. So we have been just really proud of the work that we've done, and we'll continue to keep the gas on the pedal, or foot on the gas, or whatever the expression is. You don't want to put gas on the pedal. Anyway, you get me. But to make sure that we keep up the energy and continue to support our members with redetermination.
Thank you.
Yes.
The other thing I'll add, because they've been so successful, we've started to incorporate other things into redetermination. So starting in August, we actually will be talking about cancer screening. So we've created talking points for our care coordinators to, so we can talk about other things while we're there.
Fantastic. Great. Okay.
Great. All right, on to the next slide. So I'll give an update on our food program. A little over a year ago, we implemented a comprehensive nutrition program to support our members. We started off with an emergency meals program back in January of 2023. This was expanding on emergency food program that we had implemented during the COVID-19 pandemic, where members can get support from their care coordinator to request 14 prepared meals to their homes, and then it gets delivered within 48 hours. We also then in April implemented a nutritional guidance and support program to our entire membership. So that was rolled out to a broader population where they get access to a platform. They can have support with supplemental nutrition assistance program applications. They also can get support from a registered dietitian and then follow-up appointments as well, and then dollars towards food. So that was implemented in April of 2023. And then the last component of our program is around medically tailored food. So that was implemented last June, and for a targeted group of members who have chronic illnesses, for them to be able to get meals delivered to their homes that are tailored to their condition. So those are for members with hyperlipidemia, and then pregnant members with gestational diabetes, with pregnancy-induced hypertension, and some other chronic conditions as well. And this was the program that was the best in category for the National Association for Counties Award. So we just wanted to share a little bit more information about that. If you can go to the next slide. So for our emergency meals program, this, as I mentioned, is most often referred by a care coordinator. We've so far distributed about 14,700 meals. Though we know that this is kind of a Band-Aid, we want to make sure that people are engaged in kind of longer-term nutrition support. So that's why we rolled out our second phase of the program. If you go to the next slide, our general nutrition program, as I mentioned, is getting access to a registered dietitian. So we've had about 45,700 members enrolled, which is exceeded our goal. We'd originally had a goal of engaging about 10% of our membership. And so far, 23,400 have had initial appointments. And then as you can see, many of them had follow-up appointments as well. Members receive $50 in grocery funds for their first dietitian appointment, and then $15 for any follow-up appointments. They can get support with grocery planning, with recipe planning, and then again with kind of developing shopping lists, things like that, with support of a registered dietitian. And then lastly, our medically tailored food program. This is the delivery of prepared meals that are delivered to the member's home based on their specific condition. We identify members, and then this is a much more kind of white glove service where the members receive outreach from our team and to enroll them into this program. So far, we've had about 1,400 members who are starting to receive medically tailored food, and then they receive a prescription for kind of a certain period of time based on their condition as well. And if you go to the next slide, so this is kind of very initial clinical outcomes that we've seen. So for the percentage of obese users with weight loss, we've seen about 56% who have experienced some sort of weight loss. I should have mentioned at the beginning of this that the FoodSmart Book of Business, FoodSmart is our partner that we are partnering with on this program. They were selected through a competitive RFP, so that's looking at their overall book of business. And for the average weight loss per member, that's about 9 pounds. We've also seen reductions in HbA1c, improvements for those with a reduction of systolic and diastolic blood pressure at about 55%. And then we also do a quiz at the very beginning when someone's enrolled in this program. That's called, it's called a Nutri-Score. And we've seen improvement in our members' Nutri-Score over time. So we'll continue to look at these clinical improvements. We also have seen just great satisfaction and outcomes from members as well in relation to this program. So we'll continue to share outcomes over time, and especially as we reach the 12-year mark for members who've been in the program. Yes.
Yeah, I have a question about the program we have around food, because there's this concept of food insecurity where families don't have access to affordable, nutritious food. And so I assume that's what our program is looking to do. And what percentage, do we know how many of our patient population are food insecure? Or is there any idea about what that percentage might be?
I don't know that off the top of my head, Dr. Collins.
Yeah, so probably a little over 50% when you look at the entire realm of food and nutrition insecurity.
So we're talking about hundreds of thousands.
Yes.
Yeah.
And some of those populations, I mean, some of those areas in terms, when we look at sort of the zip code breakdown, are significantly worse than others, which is some of the background why we thought this was so important when we were looking at our data even before we did the RFP. Food and housing is a significant need for this population.
Yeah, we mapped that out.
Yes.
So we know. And so we're targeting those areas that are the most food
No,
insecurity?
we're targeting all the areas
Everybody.
because it's pretty, it's everywhere. We didn't target specific zip codes for the program. As we do some provider outreach, we're doing some very specific outreach to providers in some of those more high-risk areas. But no, the program was across the board because we have so much diabetes, we have so much high blood pressure. Yeah.
Thank you.
And then specific to food insecurity, as I mentioned, there's support with Supplemental Nutrition Assistance Program applications to make that, you know, we understand $50 at the first appointment won't go super far, but making sure that that's more sustainable for our members. And then just making sure that there's kind of that education component there as well. And then we have a rewards program that also supports, and a majority of those dollars are spent on groceries as well.
The other thing I'll just add, which is another really important piece of the program, is that members learn the finance of grocery shopping. There's a really nice slide, we should probably add it, that looks at the analysis of the same set of groceries at 4 different grocery stores. And the price difference is almost $62 for the same set of groceries. So imagine if I didn't know that and I was just going to the store that I always go to. Now I know that, and my dollar goes a lot further with a different store. It's pretty significant. You know, you have double the money for the month based on where you shop.
So if you go to the next slide, so I won't go too in depth here, but basically we just always want to share the stories of our members because the most important thing is that we're getting services in the hands of people and our members. So this member shared their story about how they've been hoping for a registered dietitian for over 11 years and lost 40 pounds, gained a new love of fruits and veggies. So we'll continue to kind of raise up the voices of our members in relation to this program and how it's impacting them. And then last but not least, I'll give an update. Yesterday, we went live with our new transition to non-emergency medical transportation partner, Motive Care. We are really excited about this benefit that'll be provided to members. Members will receive private transportation providers, public transportation and bus passes, and then mileage reimbursement to and from the doctor's office, to and from pharmacies, to WIC clinics. And on the next slide, in addition to calling in, which has always been the case, members have been able to call in, providers have been able to call in on behalf of members. They'll also be able to have access to a mobile application to be able to track their rides and be able to chat and follow up directly if they have any questions about where their driver is. They'll also be able to use a website, and then all of our care coordinators have also been trained on a platform called TripCare, so they'll be able to arrange services on behalf of our members as well. So we're just so excited about this transition and really looking forward to how this impacts our members.
Well, would it be too early to ask how did day one launch go?
It went really well. So as you can imagine, we have twice a day stand-ups happening. Yesterday we did about 1,400 rides, and we've been at we've been meeting SLAs for the call center. We actually did a soft launch for the call center on July 17th. So we were able to make sure everything was running really, really smoothly before we went live with rides. And then there's a little bit of an expanded network as well from on the transportation side as well. So we don't expect any access issues. And so far things are going very well, but we'll be happy to report back in a couple more months.
Great.
Okay, and then on the next slide, there's just a view of what the app looks like, so we'll I think leave it there, but I'll pass it over to Aaron to cover our value-based care strategy.
Thanks, Chrissy. And I just want to echo the excitement I think we have about transitioning to a new non-emergency transportation solution for our members. That's something that I think historically has come through very loud and clear in member feedback that we get around just the overall experience there. And I think it's also a market that has changed a lot with more on-demand transportation options over the past, decade or so. So a lot of that is now going to be available to members. They're going to be able to see where, with the mobile application, see where individuals are coming to pick them up, et cetera. So it's I think really going to change the end experience for our members, and hopefully will be something that as we get data back on that experience, we'll be able to see some of that impact. So. All right, transitioning into value-based care, I just wanted to provide a few updates on our overall strategy and kind of where we're at in our continuing evolution to value-based care. I think, you know, we are really well positioned both in our local market and also nationally in terms of what we're doing in value-based care. I think as a provider-led plan, we're also uniquely positioned in this space. You know, at the end of the day, we are not the ones who provide care to our members. That's done by the providers, and so our goal as a plan is always to try to empower those providers to be able to provide the best care that they possibly can. And so, value-based care contracting is a mechanism to try to bring a lot of that value to the provider level and help enhance what they're able to do, be that with enhanced data that they receive, with the ability to provide enhanced reimbursement for outcomes, and also to align with some of the end goals that we have as a plan and what we're trying to incentivize. So, you know, we have, so I won't read through all of this, but I think if you go to the next slide, Deb, there's sort of a standard national framework for how you measure and evaluate value-based care. It's called the HCP LAN alternative payment model framework, and basically there's 4 categories of value-based care, the lowest level being the basic fee-for-service structure, where you're paid for the volume of visits that you do with your patients, up to category 4, which is a full population-based at-risk upside and downside risk model, where the provider is really responsible for the patient, not just while they're within the 4 walls of care, but really managing the patient overall and the care that they receive and how they engage with the member. So as you can imagine, providers are often at different levels of capacity and sophistication and what type of value-based care arrangement that they're able to engage in. And so a lot of the work that we're doing now is to try to help providers transition through these categories of this plan model to move up the scale of what they're able to do from a value-based care perspective. We've done a lot of work with our primary care providers, our FQHCs. Many of them are in risk-based models, and so are in kind of the full spectrum of that. We're trying to build more infrastructure now to help providers that aren't don't have kind of the full suite of infrastructure built. So we're trying to design ways that we can now provide more tools to providers that maybe want to start taking on, you know, links to quality, take on ability to earn some shared savings based on managing the total cost of care of the member. But a lot of that provides, you know, requires enhanced data, information, analytics, and ability to translate that into the workflows of the provider in the office. So that's a lot of the work that we're trying to build out now. And then in addition to the primary care space, we're also trying to evolve more into what we can do on the specialty side, especially to address some of the access issues we mentioned earlier, as well as hospital. There's a lot of opportunities in long-term care with skilled nursing facilities, for example. So we're really trying to broaden out the reach of the value-based care that we put in place as well. Behavioral health is certainly a top priority for us in that space, which really ties back to what our goals are from our overall quality program in that perspective. The next slide shows where we're at in terms of our overall medical spend. So we're very happy to report that in 2024, about 59% of our total medical spend, and as a reminder, we have a budget of about $3 billion, so a significant amount of spend, about 60% of that is covered under a category 3 or 4 value-based care agreement, meaning that providers are taking on some shared savings or shared risk for managing that overall spend of our population. And that's an increase from about 50% the year prior. Overall, our goal is to get to about 75%. And, you know, in addition, so I do have a finance background. In addition to the quality and all of the other great aspects that leads to, this is also a mechanism that helps us de-risk the plan over time so that we're not, as the payer, holding all of the risk in case there are, you know, shifts over time in terms of where our MLR and other things fall in any given year. So this also helps us share that risk and provide aligned incentives across all of our partners. The next slide shows I won't read this to you, but some of the feedback we've gotten from providers that we partner closely with and the impact of our value-based care relationships with them and what that allows them to do. In particular, with our primary care providers that I mentioned before, we're able to allow them to invest in care management at their practice level and really have that integrated into their workflows, which unlocks a lot of their capability to help better manage patients. And then the next slide shows some of the differentiated outcomes we see. As we mentioned before, a number of our HEDIS measures here, which align with what Dr. Collins was speaking to earlier, but we see very clearly much better outcomes for those that are engaged in value-based care arrangements with us versus our overall plan average. And then our final value-based care slide, or sorry, second to final value-based care slide, just talks about some of our goals as we move forward. So I mentioned getting to 75% in those category 3 and 4, so the most advanced APM models, you know, continuing to build out some of that infrastructure and ability to better partner with providers that are lower down on that scale of APMs, and then really continuing to drive some of the outcome-related things that we want to see, and moving not just from HEDIS measures, but also to some of the more core outcome data that we want to impact over time as well. And then finally, one thing that I wanted to mention is that County Care, along with Cook County Health, have also structured a new value-based care agreement this year. So moving Cook County Health also down this pathway. So a lot of the structure is related to how we incentivize the quality outcomes within our County Care patients that are impaneled to Cook County Health clinics. So we've listed here some of those key quality outcomes that we've provided, and then there's also a shared savings opportunity for Cook County Health based on how they manage the overall cost of care of the members that are impaneled to their clinics. And with that, I'll transition this to Alex Normington, who I think is joining us virtually to talk about our final section, which is our new marketing campaign.
Thanks so much, Erin. I'm Alex Normington, Interim Chief Communications and Marketing Officer for CCH, and I am pleased to share with you our concepts for the 2024-2025 Choice Campaign. The goals of this campaign are to raise awareness about the health plan, drive loyalty and engagement among current members, and encourage individuals to select County Care during their choice period. We brought several concepts to focus groups, both in English and in Spanish, and this was overwhelmingly the preferred concept. County Care rewards you. It's the first year that we'll be doing a campaign that's focused on our rewards program, which is really exciting. And I have to say, this is actually the first year I can remember when we had such a clear winner far and away in the focus groups. So again, this year's concept focus on the plan's rewards and the cash rewards that members can receive for doing their health assessments, getting their annual vaccines, and preventive care. And what struck me was the feedback that we got from members that not only that did these messages underscore that County Care wants them to be healthy, but that it also respects the time and the effort that they invest in going to see the doctor. On the next slide, you'll see additional mock-ups of assets in English and Spanish, and know that this will be a multilingual campaign. In addition, we will have also Polish, Arabic, and Mandarin. And my apologies, I thought we dropped some Spanish language ones in there. We can get you some copies. On the next slide, you'll see that thanks to your support, we're able to substantially increase our marketing investment last year, and we were thrilled with the results that we saw. This year, we'll have a more modest increase with a $3 million buy overall, and we expect that this again will provide a really good return on our investment. The next slide shows just a little bit more about the campaign. This will be an omni-channel campaign, and with the latest budget, we'll be able to extend the flight from September to May, so we'll be in market longer, and we'll be able to test new out-of-home tactics and some more hyperlocal and multilingual tactics that we haven't done in the past. We'll be investing in more video outlets, particularly streaming TV and broadcast, more Spanish language outlets that have performed really well for us. And with the longer flight, we'll also be able to swap out our creative more frequently, particularly on digital, to maximize the messages that are performing really well and keeping the campaign fresh and engaging for folks. And finally, the campaign will be driving people to visit County Care's website or call the call center for more information, which is one of our main KPIs. And on the next slide, you'll see a map of the zip codes that we'll be targeting. I love this map because to me it shows an evolution of the health plan over the last 10 years. There's historic Medicaid zip codes. Those are the ones that we really focused on in the early years of the plan when we were enrolling ACA adults. Then we were able to expand to what we call opportunity zip codes, or areas where there's additional market share potential. And every year we do a fresh deep dive into the zip code level data to look at Medicaid enrollee density across the county, where County Care has a strong foothold, and where we have the opportunity to grow, particularly in alignment with where there's good network strength. So based on this analysis, we're adding a few new opportunity zip codes. You'll see those in the pink color, and those are adjacent to a number of opportunity zip codes that will expand our reach in those areas where there's a large pool of potential enrollees. And with that, I'd be happy to answer any questions about the upcoming campaign.
No question, but again, a tip of the hat to the hard work that the teams have put in here. By all counts, the ROI has been very positive on the most critical areas, retention during the READY period as well, new membership coming in, identifying those areas where we get the most positive impact of this type of visibility. So again, I think we're on a fantastic glide path here today and moving forward, and would certainly encourage the team to continue in that direction. It's been a great benefit, not only to the people who ultimately join County Care, but I think there's residual benefit just of visibility for those who've not yet necessarily made a selection or get involved in managed care in some other way. The residual benefit of us putting that information out educationally in these communities. Thank you. Thank you
so much.
And thank you. I also just want to take a moment to thank Alex and her team, who really we've seen just constantly improving results with our marketing campaigns. And I think we've also really enhanced our ability to tie in what we're doing from a marketing perspective to the strategies that the plan have, be that where we're adding network providers and trying to drive growth into the health plan in certain geographic areas. And also, building out content related to quality and engagement of our members. So can't thank that team enough for all the work. And then also want to offer Alex my apologies. I was the one responsible for messing up the version control of the slide deck. So why you did not see the Spanish creative that was in there, but we'll make sure we bring that back at some point.
We absolutely will. Thank you, Aaron. And I'll echo that. Just thank you to the collaboration. We've seen some great alignment and strategic thinking between the managed care and marketing teams. And I think we see that in the data of our campaign results. So thank you.
With that, I'm happy to answer any other questions. That concludes our presentation.
Okay. Thank you. No action is required. This is only to present the information. So I'd like to move on to item 4, and this is meeting minutes from the April 19th meeting. They were approved by the board at the April meeting, but are being presented for the committee's review and discussion. Chair I'd like to ask if, there are any corrections or edits that need to be made to the minutes. Hearing none, I'd like to entertain a motion to accept the minutes of the Managed Care Committee meeting of April 19, 2024.
So moved.
Second?
It's been moved and seconded. All in favor?
Aye.
All opposed? The ayes have it. The motion carries. As the agenda is exhausted, we can adjourn the meeting. The meeting is adjourned.